So iron deficiency is the most common global micronutrient deficiency, uh, and especially is one of the leading causes of years lived with disability around the world, particularly in low and middle income countries, where often case it's one of the top causes of years lived with disability. Um, Clinically and for patients' experience of their health-related quality of life, incredibly important. Being iron deficient comes with a lot of very frustrating, sometimes non-specific symptoms, fatigue, um, impaired mood, impaired cognition, just a feeling of mental fog, poor quality sleep, and the like. And yeah, currently ferritin, serum ferritin is our most, readily available way of diagnosing iron deficiency. Uh, Unfortunately, many clinical laboratories in the United States have very, very lower limits of normal for what they consider to be like the lower limit of a normal ferritin, which results in the underdiagnosis, or simply put, like non-diagnosis, undiagnosed of women with iron deficiency, especially women of reproductive age, because of their obligate menstrual losses, and the fact that they need more dietary iron to replete their stores. Yeah, even the current World Health Organization guidelines have the lower limit of normal for serum ferritin at 15 micrograms per liter, whereas we know from physiologic studies, translational, clinical, basic science, that a more appropriate threshold is probably 25 to 30, maybe even as high as 50 micrograms per liter. So a huge swath of women of reproductive age who are just going undiagnosed and untreated in a lot of cases. Historic, data from where a lot of the clinical lower limits of normal currently sit at, like where the research comes from is, like historical studies of very, very small sample sizes of women. And really, when you want to establish like a reference interval for any screening test or any lab test, you want it to come from a normal and healthy population of people. Unfortunately, we suspect that when these reference intervals were first being established, a lot of the women whom they, did bone marrow biopsies on and stained for iron to determine like what the appropriate threshold should be, were probably iron deficient, because we know now it's a lot more prevalent, really affects a lot of people. And so that's also where a lot of the physiologic data, as I mentioned, is pointing to, and really has been pointing to for a long time. Our study is really building on the work of so many hematologists and primary care docs and OBGYNs who come before us, really advocating for raising the screening threshold for ferritin across the board, because we know more now and we know better. Yeah. A lot of the symptoms are very non-specific. They're very frustrating for folks to deal with. And the real tragedy is that if appropriately screened and identified, as iron deficient, the treatment is very simple. Iron supplementation is by and large well tolerated. And for folks who can't tolerate oral iron, or who are very heavy menstrual bleeders, or who have other bleeding diatheses, IV iron is also a very safe and well tolerated option. Just kind of underscoring the fact that this is much more prevalent than maybe a lot of people think. And then, obviously a lot of this screening we hope will take place in the primary care setting. And, we really, really appreciate all of our primary care providers. And, they have so many sort of different tasks to juggle when it comes to patient care. And they're really, taking comprehensive care of the patient. So we really hope that, standardization of these screening thresholds will help make life a little bit easier for them as well, and then properly identify patients and have them treated. But absolutely believe that it contributes to productivity loss and really just, a loss of quality of life all around. Our study was really interested in comparing 3 different strategies for screening for iron deficiency. Screening at, the first being no screening at all, unfortunately happens in some cases for women who just go unscreened and just completely undiagnosed. The second strategy being screening at the WHO standard, which is a lower limit of normal of 15 micrograms per liter. And finally, an increased screening threshold of 25 micrograms per liter, which we know is, much closer to what is physiologically accurate. So we built a Markov cohort model, and, patients are simulated through our model through thousands and thousands of iterations, and they undergo, transition probabilities that determine which health states they fall into. And all this is based on, the highest quality clinical and epidemiologic data that we have available. So these are not just, hypothetical patients, but we do our best to make sure that the inputs of our model mimic clinical reality. And, the results of our model show that screening at 25 micrograms per liter is cost effective. It does not matter if after women are identified to be iron deficient, they're treated with oral iron supplementation or intravenous iron supplementation. Regardless of the treatment strategy, after iron deficiency has been identified, screening at that higher threshold is cost effective. The message I'd love to leave for folks is what our findings really suggest, especially with the incremental cost effectiveness ratio as low as we've found them, really far, far below the currently commonly accepted willingness to pay thresholds in the United States, is that cost should not be a barrier for the screening and treatment of these women. And at a population level, if we can raise the bar, I really think so many people would benefit. We really anticipate, first and foremost, the ASH guidelines on the diagnosis of iron deficiency. We understand that a group of renowned experts and leaders in this field have been assembled to really put forth what the American Society of Hematology deems as the appropriate screening threshold for ferritin. And we absolutely hope that they will come to a conclusion that we should, raise the bar towards a more physiologically appropriate screening threshold for ferritin. In terms of our work in particular, we're absolutely interested in pursuing this further. First and foremost, to expand this to a global context. As I mentioned earlier, iron deficiency, whether because of heavy menstrual losses or just because of malnutrition, affects so many women in the world, not just in the United States. And it's an issue of equity. It's an issue of global health. And so we'd love for, as high quality data becomes available in other jurisdictions, to expand our model to especially the low and middle income country context. And finally, thinking also about pregnancy, which we don't explicitly examine in our model, in which, the US PSTF currently has stated that there's inconclusive evidence for the screening of iron deficiency in pregnancy. We're really interested in honing in on that question and seeing what our model bears out in terms of, the cost effectiveness of screening for iron deficiency in pregnancy. And really, what cost effectiveness is trying to answer is the value of that intervention. Yeah. So hoping that it's, that we get some exciting results from all that future work.